In this episode, we will discuss traveler's diarrhea. This is a continuation of our travels medicine or GI disorders or infectious diseases. Remember, please, that in assessment and management of traveler's diarrhea, the focus is not a microbiologic assessment. Rather, the focus is to know indications for stool examination, indications for antibiotic treatment, and indications for prophylaxis. True or false, most cases of traveler's diarrhea would not need antibiotics given the fact that most cases are due to viruses. This is false. First of all, many cases of traveler's diarrhea will benefit from a single dose of an antibiotic, especially if no contraindications is present. And second, and most importantly, up to 80% of all cases of traveler's diarrhea are due to bacteria and not viruses. Now, what are the most common causes? First and foremost is enterotoxigenic E. coli. You remember, the sister of Vibrio. Then we have Shigella and Campylobacter. Less common causes include Salmonella, Aeromonas, non-cholera Vibrio, some parasites such as Entamoeba histolytica and Giardia, and finally, for less than 20% of cases, but more so among children, we have viruses such as rotavirus and adenovirus. Now, important question is, what are the causes of chronic watery diarrhea among travelers or in general? Always remember Entamoeba histolytica, Giardia, and tropical sprue among travelers. Now, what is the overall most important decision point question approaching traveler's diarrhea? As usual in the cases of acute diarrhea, the most important point is to figure out if we are dealing with an invasive inflammatory type or a non-invasive type. And in resource-limited settings, this means presence or absence of fever. True or false, presence or absence of blood is the most reliable means to differentiate between invasive versus non-invasive diarrhea. That is false. Remember that there are certain toxin-producing bacteria, especially those producing cytotoxins, for example, by inhibiting protein synthesis, that will cause bloody stool without much inflammation. And on the other side, we have some inflammatory causes of diarrhea, especially those inflammatory causes that are due to toxins again, such as C. diff, that are inflammatory. That means stool will be positive for inflammatory diarrhea, but they are non-bloody. So stay with fever. However, if you are not in a resource-limited setting, what is the most reliable test to differentiate inflammatory or invasive from non-invasive, non-inflammatory diarrhea? That is presence of leukocytes in stool and especially their lactoferrin. This brings us to the next question. What are the indications of stool culture in the assessment of traveler's diarrhea? While we say most cases are diagnosed on the clinical basis, presence of inflammatory diarrhea or presence of blood in stool or lack of response to antibiotic treatment are all indications for stool culture. What is the simplified management of traveler's diarrhea? Management begins with rehydration. If the patient is distressed, we consider antimotility agents, and if diarrhea interferes with the purpose of travel, regardless of invasive or non-invasive type, we consider a single-dose antibiotic. Regarding fluid management, remember that oral rehydration fluid packages such as Pedialyte or ORS for patients who have oral fluid tolerance are the first step in the management. If the patient has signs and symptoms of severe diarrhea and is dehydrated or has unstable vital signs, or if the patient can't tolerate oral rehydration fluid, next step will be IV fluid management. What is the preferred antimotility agent? The preferred antimotility is loperamide, and remember, bismuth is not the first antimotility agent of choice. When do we use antimotility agents? Again, when the patient with traveler's diarrhea is distressed and has no contraindications to antimotility agents. So what are the important contraindications to use of loperamide in patients with diarrhea? Presence of inflammatory symptoms or signs, as well as presence of blood in stool. Remember, why is it so? Because use of antimotility agents with loperamide or bismuth would slow down the bacterial clearance and would result in more toxin production and worsening of diarrhea. Why bismuth is not favored much anymore? For at least two reasons. One is its side effects, for example, darkening of the stool, and the other is many patients that require any type of management of traveler's diarrhea may be in a setting that may also require antimalarial agents and prophylaxis such as doxycycline, and bismuth would interfere with those agents, for example, in their absorption. Now, we initially mentioned that if there is no clear contraindication, we feel free to provide patients with a single-dose antibiotic for traveler's diarrhea. What's that antibiotic initially? Single dose of a fluoroquinolone would help alleviate symptoms, especially in distressed patients in whom diarrhea may interfere with the purpose of the travel. However, there are clear indications for azithromycin 1000 milligram, which is usually given on 1 to 3 days. What are they? First of all, if the patient has no fluoroquinolone response, or if the patient has invasive or bloody diarrhea. Also, if the patient has clear contraindications to fluoroquinones. This brings us to our first case. A pregnant woman is traveling to Southeast Asia and has diarrhea and fever. After rehydration, what is the next step in the management of this patient? Remember, fluoroquinolones are not indicated for pregnant women. This lady clearly requires antibiotic management given the inflammatory type diarrhea. In pregnant women, azithromycin is the drug of choice. Next case is a representative of a tourist organization who is coming to our office asking about which one of the travelers to India will benefit from antibiotic prophylaxis. What are the indications for antibiotic prophylaxis for travelers' diarrhea? Simply remember presence of underlying disease, especially inflammatory bowel disease, diabetes, immunocompromised status, and especially remember elderly patients with underlying heart disease. These are the patients who will benefit from antibiotic prophylaxis. What are the agents used for prophylaxis? Either a single dose fluoroquinolone or rifaximin and rifampin, like drug rifaximin. Now, when rifaximin is not indicated, when there is inflammatory type diarrhea or the risk of it, given the fact that rifaximin has no systemic absorption, it is not indicated for systemic or inflammatory invasive diarrhea. Now, I would like to finish this episode with a case on when we should avoid the antibiotics in diarrhea. So, first case is a patient with bloody diarrhea who has tenesmus, that is abdominal cramp and passage of mucus in stool. This patient also has fever but denies any meat product consumption recently or any animal exposure. Does this patient need antibiotic treatment? The case is typical case of bacillary dysentery given the presence of fever and tenesmus, and this patient benefits from antibiotics. Next, we have a kid who has bloody diarrhea a couple of days after visiting a petting zoo. He does not have fever. Does this patient benefit from antibiotics? So this is a challenge because you may simplistically think that any patient with bloody diarrhea benefit from antibiotic. However, in this case, we are dealing with Shiga toxin producing enterohemorrhagic E. coli mediated hemorrhagic colitis. Please don't call it dysentery. This is hemorrhagic colitis because the patient does not have tenesmus or passage of mucus. And these patients, especially if among pediatric patients, will have high risk of hemolytic uremic syndrome, especially if treated with antibiotics. So you should avoid antibiotics at all costs in this patient. Put it simple, Shigella has fever and tenesmus and no animal exposure because the common mode of transmission is person to person, while enterohemorrhagic E. coli does not have fever, but there is a history of animal exposure or hamburger consumption, and antibiotics are contraindicated. Thank you. This finishes our discussion of traveler diarrhea.